Is it time to ask questions?
Yes, sir. Please go ahead.
Has Dr. Rajanag presented? Dr.
Yes,
Rajanag?
sir, I presented.
Oh, sorry. Okay.
I have a comment to make on pediatric heart failure. Patient with history of left heart failure suddenly collapses with features of cardiogenic shock. And it would be a good idea to start prostaglandin infusion and look for severe coarctation. Because the doctors may be supplying the aortic systemic circulation, and closure of the ductus may have caused the severe aortic flow reduction and shock. What is your opinion in this matter?
Sir, before doing that, we can palpate the femoral pulse.
Yes.
If femoral pulse is not palpable, then only we can go for that.
Coarctation is very important entity. Should not be
Yes.
overlooked in heart failure.
Yes, sir. Yes, sir. Right, sir.
Can we go to the other speakers?
Yeah. I think the next session is due at another 15 minutes. But can I ask a question to Dr. Bhattacharya? Sorry, it's
Yes, sir.
Shubhra Banerjee here. You did mention about. Sorry, I wasn't actually present throughout your talk, but did you mention regarding mevacamptine when it's available? Do you think dosing may be a problem? Because at this moment, go on.
Yes, sir, exactly. The problem with mevacamptine mud, we don't have it till now, but the studies that has been made with this molecule, it needs a close observation for titration of the dose. Initially, it was started at 5 milligram per day dosage, and serial echocardiography at least 4 weeks interval was done to assess the improvement and also the reduction in LV function. Although it was found the LV reduction in LV dysfunction, LV ejection fraction is not significant, but some patients showed ejection fraction below 50% after some duration of therapy, and at that period the treatment was stopped for a few time, and it was started again on a lower dose. And to titrate this dose, it needs a problem. It's a very close evaluation, and monitoring is needed when a patient is on mevacamptine.
So we may even be needing those blood levels too when we initially start.
Exactly.
I have a question to you. In drug refractory HCM heart failure, when you've tried everything and need replacement therapy, how should you approach the problem?
Yes,
how to select a device?
Yes.
How to
5%
select?
of patients with non-obstructive HCM usually lands up in end-stage heart failure. As the studies has shown, the prognosis is relatively better in HCM compared to other heart failure subsets. And it's just like when a patient ends up in end-stage heart failure with ejection fraction less than 30%, we should treat it as any other decompensated heart failure. If the patient fits the criteria for CRT implantation, we'll go with the CRT. If the patient is a candidate for heart transplant, then heart transplant is the option. Usually, patients with obstructive HCM usually don't land up in this type of scenario.
If there is an obstructive HCM, then septal myectomy will be improving the prognosis.
Yes, that is the only option, and that usually solves the problem.
If it is a burnt out HCM, you can try left ventricular assist devices. But better option is cardiac transplantation.
Which to transplant we can.
But certain subsets of patients with HCM heart failure have narrow cavities and thickened walls, and it is a problem in putting in an impeller device because the inflow catheter gets obstructed by the hypertrophied septum and the papillary muscles, and there is a slowing of the circulation and thrombosis of the cannula, and repeated suction can produce arrhythmias. So in this situation where the cavity is less than 5 centimeter, a small LV size cavity, you better not to go for a left ventricular assist device implantation. So best option would be cardiac transplantation as the destination therapy. Okay.
Yes.
Can I ask a question to Dr. Nag? Dr. Raja, are you still there?
Yes, sir, I'm here.
Okay. See, at times, I think in elderly people, I mean, they often comes with vague symptoms, shortness of breath, exercise intolerance, and all. So, how do you detect heart failure in these patients? But when your suspicion would be strong, I mean, sometimes it could even be heart failure with preserved ejection fraction. So, when would you really start investigating these patients? Otherwise, I find very old, more elderly patients would, if you ask them, they would either they wouldn't say anything because they have learned to adapt to their symptoms. They are not that mobile, but they may be having heart failure. And how you suspect and how you prove it?
Yes, sir. So basically, a patient who is elderly will be having multiple chronic conditions. Now, we need to distinguish whether it is from COPD, whether it is from heart failure with preserved ejection fraction, or any other comorbid condition. So, let us take an example. 80-year-old comes to our OPD, has new onset atrial fibrillation, has breathlessness. So, we need not do any further test to understand that this is a patient because of his new onset atrial fibrillation. Although his ejection fraction may be normal, he is a candidate who is having heart failure with preserved ejection fraction, and he needs treatment for that. Now, there are several other pointers to which I allude to when patient comes to me, particularly elder patients who come with symptoms of heart failure. And also, I take the support of adjunct investigations in the form of echo. Echo is common in such patients, and if that diastolic dysfunction is also having severe symptoms, then I am sure that I am dealing something like that with heart failure with preserved ejection fraction. And not to mention about patients who already have cardiomyopathies, diabetes, long-standing diabetes, CKD, anemia. So that is how I go about it.
Yeah, another problem I think is with the biomarkers, the anti-proBNP. That
Yeah,
also
that is
includes
why
the
I didn't
age.
mention. I didn't mention
Yeah.
that particularly,
Mhm.
knowing
Mhm.
that these patients will always have a high anti-proBNP. Now, if it is 2 or 3 times the normal range, then I would give importance to that, along with the symptoms or my echo findings. I would not only give importance only to the biomarkers or anti-proBNP, which we do in younger patients.
I agree. These elderly people have diastolic dysfunction, thickened walls, and elevated BNP levels, pro-BNP levels. So these are just finding these items doesn't make it a diagnosis of the heart failure. You have to correlate clinically. Dr. Nag, what is unique in geriatric cardiology care with special reference to heart failure patients? What special things to look for? You have mentioned the multiple comorbidity and anything else? Polypharmacy is there.
Yes, treating such elderly patients with heart failure is really a challenge. And what I would do is try to minimize their polypharmacy and try to combine pills wherever it can be done, and minimize the number of drugs they have to take per day to as low as possible, along with supportive treatment from their family, which is very, very of utmost importance. So these patients frequently end up with electrolyte imbalance and dyselectrolytemia because of poor dietary intake or fluid intake. So any patient, elderly patient with heart failure, has to be having a multi-pronged approach to give them a good quality of life.
Exactly. So patient should not be clinic centric, rather than the care should be patient centric or care centric approach. Skilled nurse should be there, and comprehensive management discussion should be done with the patient and the party, because the problems are also there. The cognitive dysfunction deficiency is there, and the frailty is there. The unable to cope with acute stresses of daily life due to vulnerability and the decreased reserve and functioning of the physiological systems. Frailty is an important issue. And frailty, depression, they all also contribute to increased heart failure. What is your opinion about the BMI and elderly heart failure? Do you have any comment about the BMI? Am I audible?
Yes, you are.
There is a U-shaped relationship between BMI and heart failure in the elderly. Best prognosis is seen with BMI around 30, and was if the BMI is 20 or 40, the heart failure prognosis is not that good. So keeping the patients with BMI at around 30 will fare better in heart failure with elderly. Dr. Banerjee?
No, yeah. I think we are still some 10 minutes we have for the next session. I was thinking like we do not have all the chairpersons for the next session yet. So maybe we should, because this has happened because one of the speakers couldn't deliver his talk. So I think we can carry on the discussion for a few more minutes.
Can we discuss the Takotsubo cardiomyopathy briefly?
Yeah, that is something. Why don't we discuss that? Because no one has presented it. But even if we could have had the presenter slides, we could have discussed anyway.
But we can discuss it briefly.
Yeah, sure.
It is acute transient myocardial stunning, neurogenic stunning, usually reversible, caused by psychological and physical stresses, and characterized by apical wall motion abnormality like ballooning, akinesia, hypokinesia with or without mid-wall involvement. Now, this apical variety consists of 70 to 80% of cases of Takotsubo cardiomyopathy heart failure and Takotsubo cardiomyopathy presentation. And 10% are the mid-ventricular level obstruction with apical sparing, and 5% will be basal. Normally, the basal segment shows hyperkinesis, but here in the less than 5% cases, the basal wall motion abnormalities are seen. The pathophysiology is cardiac stunning, myocardial stunning because of release of stress hormones like norepinephrine from the brainstem, from the neuropeptide Y from the hypothalamus, in response to acute stress, physiological or physical stresses, psychological or physical stresses, and there is release of norepinephrine from the postganglionic presynaptic adrenergic nerve endings, and this storm of catecholamines causes the direct toxicity and microvascular dysfunction, leading to wall motion abnormalities and decreased cardiac output. Now, the prognosis of is good, generally better than in acute coronary syndrome, but sometimes you have some serious complications like arrhythmias, cardiogenic shock, LVOT obstruction, mitral regurgitation, which can worsen the clinical scenario. The management of cardiogenic shock is interesting in Takotsubo. It depends whether the patient has LVOT obstruction or not. In case of LVOT obstruction, it is important not to give inotropes or IABP and impeller devices, because that will worsen the cardiogenic shock. Better to go for septal myectomy. But in non-obstructive DCM, Takotsubo, you can go for inotropes, vasopressors, and the usual treatment. And to prevent recurrences, beta blockers have been shown to be useful. Dr. Banerjee, any comments on Takotsubo?
No, I think you have nicely covered most of the important things about it. Therapy post Takasibo is something which is still being debated, and whether the place of beta blockers may or may not be what we thought it should be. So, but then there's also a new sort of concept about giving ACE inhibitors to these patients. Regarding, we of course aspirin at times given for a very short period of time, but we know, but if you look at the physiology, it's not thrombosis. So there's no role for long-term aspirin. Whether you give it during the course of the illness is something which is debatable. And of course, most important is about the management, as you have said, like the obstruction is most important. If there is obstruction, then we shouldn't be using inotropes, which can further worsen the situation. And there would be some chances of recurrence are there. Recurrence could happen somewhere else as well, not necessarily the type which was in the first place. Like apart from being apical, it could be basal, it could be mid ventricle, and there are other rare forms involving the right ventricle and both the ventricles as well. But these are very rare. Most important, most common is the apical. The Garten variety is the apical variety. And yeah, I think we have more or less covered everything. So it's just a few minutes to go. So I think it's time we could move on to the next session, and would like to thank all the speakers and the chairpersons for their talk and for the discussion. So Chandrima, is that okay, Dr. Chatterjee? Should we move on to the next session?
Yes,
then?
I think we should move on. Thank you very much.
Thank you. So Chandrima, could you ask the chairperson?
Shall we move on to the next session? Yeah.
Please.
Thank you, sir.
Thank you, Dr. Banerjee. Thank you, respective speakers and the panelists and the
Yes, sir.
chairpersons. And with that, we will move on to the next session for today.